Assalamu alaikum wa rahmatullahi wa barakatuh. I am Professor Maha Abu Hashim, Professor of Pathology, Mansoura Faculty of Medicine, and today we will speak about amyloidosis. Our objectives today are to define amyloidosis and to describe the pathogenesis, chemical and physical nature of amyloidosis, the biochemical forms of amyloidosis, morphology and stains, clinical patterns, and organ amyloidosis. Finally, we will speak in short about how to diagnose amyloidosis. So let's start with the definition of the disease. What's amyloidosis? Amyloidosis is a condition in which there is deposition of abnormal extracellular fibrillary protein. That's called amyloid. This fibrillary protein is deposited in many tissues and organs. Amyloidosis is associated with a number of neoplastic, inherited, and inflammatory disorders. So it is associated with a variety of clinical diseases. Amyloid is deposited extracellular and it causes structural and functional damage to the involved tissues and organs. Basically, amyloidosis is a disorder of protein folding. So I have basically some sort of abnormal protein that may be misfolded protein. And it is produced by aggregation of insoluble misfolded protein. And as you know, normal folded proteins are soluble. So the insoluble form is misfolded protein. So amyloidosis may be a sort of misfolding of protein, or it may be formed by protein fragments. Amyloid also contains, in addition to the fibrillar protein, contains abundant charged sugar groups that have staining characteristics that are very characteristic and give the amyloid its staining character. This charged sugar resembles starch or amyloid, and so amyloid was named amyloidosis after these polysaccharides and were called amyloid. But it was proved later on that these deposits are not related to starch, it is fibrillar protein. Amyloidosis is usually a systemic disease. Sometimes it is localized to a single organ. So, amyloidosis represents misfolded protein aggregated in tissues or fragments of protein. It was previously called amyloidosis as they thought once that these deposits are some sort of starch, but it was proved that it is a fibrillar protein. Amyloidosis is usually systemic, generalized, and sometimes it is localized to a single. Now, what's the pathogenesis of amyloidosis? As we have just said, it is an aggregation of misfolded protein. So the main idea that I have a stimulus which results in the production of excessive amount of soluble precursors. These soluble precursors cannot be dispensed, cannot be proteolytic, cannot be get rid of, and they are so deposited as insoluble fibers. An example is sometimes I have a carcinogenic agent that will result in monoclonal B lymphocyte proliferation, and these B lymphocytes will change to plasma cells. These plasma cells will produce immunoglobulin light chains. This excess amount of immunoglobulin light chain will have limited proteolysis. We can get rid of this increased amount of light chain, so it is deposited as fibrillar protein, which is called AL amyloid light chain protein. So I have a stimulus with production of excess soluble precursor. These excess soluble precursors cannot be get rid of, and they will precipitate or aggregate as insoluble fibrils, which is the amyloid. This is an example. Another example is if I have chronic persistent inflammation, this will result in macrophage activation with the production of cytokines interleukin 1 and 6. These cytokines will stimulate the liver cell to secrete excess serum amyloid associated protein. So I will have an excess of this protein with limited proteolysis. I can get rid of this excess protein, which will result in deposition or aggregation as amyloid associated protein. And this is another type of amyloidosis. So the idea here, I have a carcinogenic agent that will result in monoclonal proliferation of B lymphocytes. B lymphocytes will change to plasma cells. This will secrete excessive immunoglobulin and immunoglobulin light chains. There is incomplete breakdown of proteolysis, and this protein will be deposited as amyloid light chain protein. This is one type of amyloidosis. In the other case, here I have chronic inflammation as for an example, as an autoimmune disease. This will activate macrophage with the production of interleukin 1 and 6, which will stimulate the liver cell to secrete excess amount of serum amyloid associated protein. This excessive amount undergoes incomplete breakdown or incomplete proteolysis, and this will result in the deposition of amyloid associated protein. A third example, if I have a gene mutation of the gene coding transthyretin, this will result in mutant transthyretin, this abnormal protein secretion. There will be aggregation of transthyretin, and this transthyretin is resistant to proteolysis, and I will have a third type of amyloidosis, amyloid transthyretin protein, which will be deposited as amyloidosis. So this is a code, this is another code, and this is another code. Here is, I have some source of protein, here is another source of protein, and here another third type of protein. So amyloidosis may result in different clinical conditions with different chemical composition of the fibrillar protein component of the amyloid. What's the chemical nature of amyloidosis? From the previous discussion, it is clear that amyloidosis is not a single substance. I have different types of protein. So it is not a single substance, but a group of substances that share a common physical structure. So what's fixed about amyloidosis is its physical structure, and it can be formed by different types of protein, amyloid light chain, amyloid associated or transthyretin. It is derived from many different precursor peptides, which represent fragments of larger protein. It is deposited as a meshwork of rigid straight fibrils. Each one is 10 to 15 nanometer in diameter, being composed of the precursor peptide lined up in an anti-parallel beta-pleated sheet configuration. What's the meaning of this sentence? Here I have the unit of amyloidosis. I have these blue strands are the fibrillar protein. These fibrillar proteins can have different chemical composition, Al, AA, or TTR. What's important or what's constant about amyloidosis are two things. Number one is this physical arrangement in beta-pleated sheet configuration, anti-parallel beta-pleated sheet configuration. This peculiar arrangement of the fibrillar protein, this gives the amyloid its structure. The second cause for formation of the amyloid is this constant negative charged sugar, which is called Congo red molecule, or this polysaccharide. This polysaccharide is fixed in all types of amyloid, and it is responsible for the stability of this physical configuration and for the staining properties of the amyloid. So I have a protein, fibrillar protein, and I have linked or linking polysaccharides for amyloid. So it is deposited in a meshwork of rigid, straight fibrils, 10 to 15 nanometer in diameter, being composed of precursor peptides lined up in anti-parallel beta-pleated sheet configuration. This is the physical configuration of the amyloid that can be proved by electron microscopy. It is this physical arrangement of the constituent peptides that make a protein an amyloid, rather than the chemical composition of a certain protein. This is the fibrillar component. They are lined in anti-parallel pattern, beta-pleated anti-parallel fibrils, and this physical configuration gives the amyloid its specific formation or its specific character. The second part is this polysaccharide, which is called Congo red molecule, as it is responsible for the staining properties of amyloid. This is by electron microscope to show the fibrillar pattern of the. So the chemical nature of amyloid, I have a fibrillary protein which constitutes about 90 to 95% of the amyloid molecule. This is the fibrillary protein. The fibrillary protein is of three main types: Al, amyloid light chain, AA, amyloid associated, and TTR, transthyretin. They are antigenically different, and they are deposited in different clinical conditions. Al here in plasma cell proliferation, AA here in chronic inflammatory condition, and TTR in the gene mutation of the gene of transthyretin. Second component of the amyloid molecule is the proteoglycans and glycosaminoglycans, serum amyloid B, this pink part of the molecule. These constitute 5 to 10% of the amyloid molecule. They represent 5 to 10% of the amyloid structure. They are constant in all types of the amyloid, and they are responsible for the stability of the molecule and to the staining properties of the amyloid by Congo red. So they are called Congo red molecule. This is the chemical nature of the amyloid. I have fibrillar protein, and I have the proteoglycans, glycosaminoglycans, and serum amyloid B, which is responsible for the stability of the amyloid molecule. So, what's the biochemical forms of amyloid? Amyloid consists of three major distinct proteins and about more than 20 minor forms of protein. The major forms are AL, amyloid light chain, AA, amyloid associated, and amyloid beta amyloid. The AL, that's called amyloid light chain protein, or sometimes it is called, or it is known as primary amyloidosis. This AL consists of complete immunoglobulin light chain or amino acid terminal fragments of the light chain or both. So it is an immunoglobulin. It is produced by plasma cells and is associated with some type of monoclonal B cell proliferation, for example, in plasma cell tumors. However, it is called amyloidosis, primary amyloidosis. Sometimes this primary amyloidosis can occur without plasma cell discreases, without multiple myeloma. And this occurs in most of cases with the AL amyloidosis or primary amyloidosis. So the majority of patients with AL amyloid do not have multiple myeloma or any other clear plasma cell neoplasm. But almost all these patients have monoclonal immunoglobulins or free light chain or both in their serum. If we do bone marrow for these patients, we will see that most show increase in the number of plasma cells, which secrete the precursor amyloid light chain protein. Thus, these patients may represent plasma cell discreases characterized by production of excessive amount of immunoglobulin light chain without producing a tumor mass. So I have increased immunoglobulin, but I don't have a tumor mass formed of plasma cell as occurs in multiple myeloma. These occur in most of patients with AL amyloidosis or what's called the primary amyloidosis. So primary amyloidosis can occur with multiple myeloma or plasma cell tumor or by increase in the plasma cells in the bone marrow with excessive amount of immunoglobulin without an overt tumor. The second biochemical form of amyloid, the second type of major form of is AA, amyloid associated protein. It is non-immunoglobulin. It is derived from a larger precursor in the serum, which is called serum amyloid associated protein synthesized by the liver. Increased sensitivity of serum amyloid associated protein occurs under the influence of cytokines interleukin 6 and interleukin 1 during the process of inflammation. This type AA is associated with chronic inflammation and it is called secondary amyloidosis. The third major type of amyloid is amyloid beta amyloid. It is derived from a transmembrane glycoprotein called amyloid precursor protein, APP, amyloid precursor protein. This type of protein is found in the cerebral lesion in patients with Alzheimer's disease. So I have three major biochemical forms of amyloidosis, AL, AA, and A beta amyloid. What are the minor forms? Examples of the minor forms are transthyretin or what's called TTR. It is a normal serum protein. Transthyretin is a normal serum protein that functions to transport thyroxine and retinol. Mutation of the gene coding the TTR alters its structure. I have altered protein, abnormal TTR. This protein misfolds and is deposited as amyloidosis. This type TTR is found in familial amyloid polyneuropathy and in heart of aged individual, which is called senile systemic amyloidosis. This is one of the minor forms. Another one of the minor forms is called beta 2 microglobulin. This beta 2 microglobulin is a normal serum protein. Amyloid fibril subunit, namely amyloid beta microglobulin, is derived from beta 2 microglobulin, and this type of minor component is found in amyloidosis of patients of long-term hemodialysis. So, in patients with long-term hemodialysis, I have deposition of beta 2 microglobulin to cause amyloidosis. And then we have other minor types as serum amyloid beta P component, proteoglycans, and highly sulfated glycosaminoglycans. So this is the biochemical forms of amyloid. I have major form and I have minor form. Each one of them is deposited in certain clinical situation. It has its chemical composition, but it is a type of amyloidosis associated with certain types of disease. What are the morphologic features of amyloidosis? Number one, amyloid is characteristically extracellular in its position, and it is mostly deposited near basement membrane of epithelial cells or basement membrane in blood vessels. Grossly, the amyloid stains brown with iodine. If I have a gross specimen and I put iodine, it will stain blue. To confirm that this is amyloid, then put 1% sulfuric acid. The amyloid will change to blue in color. So this is the gross staining. This is a specimen suspected to have amyloidosis. With iodine, I have brownish area. If I add to this iodine sulfuric acid, the amyloid areas will stain blue like that. In routine hematoxylin and leucine stain sections, amyloid will appear as amorphous eosinophilic appearance. So if I see this picture, I suspect amyloidosis. How to confirm that this homogeneous red substance is? To confirm this, we stain with Congo red. Congo red will stain the amyloid areas red. How to confirm? Seeing it under polarized light, the amyloid will stain by green birefringence, apple green birefringence. So amyloid is stained red with Congo red, giving apple green birefringence when viewed under polarized light. This reaction, this appearance under the polarized light is due to the cross-beta-pleated configuration of the amyloid fibers, and this can be confirmed by electron microscopy. Also, I have further stains for the amyloid. By Van Giesen, amyloid will take the khaki color. By Alshem blue, and due to the presence of glycosaminoglycans, it stains blue. Impulse periodic acid shift, it will stain pink. With methyl violet and the crystal violet, this metachromatic stain gives rose pink color of amyloid. With thioflavine T, which is not specific for amyloid, but amyloid gives fluorescence when viewed in ultraviolet light. The most specific stain for amyloid is the immunohistochemical staining using antibodies against AA, AL, and trans. What are the clinical patterns of amyloidosis? The deposition of amyloid may occur as a primary disease, which is called immunocyte dyscariasis with amyloidosis, or in a secondary form in the course of other disease, which is called reactive systemic amyloidosis, or in a heredofamilial form. In each case, there is an accumulation of a precursor peptide, which is processed into an amyloid protein with extracellular deposition. The disease may be localized, or more commonly, it is asystemic, affecting more than one organ. So these are the clinical patterns of amyloidosis. I may have systemic or generalized amyloidosis affecting more than one organ or tissue. Immunocyte dyscariasis with amyloidosis or primary amyloidosis. Here I have immunoglobulin light chain. The fibrillary protein is AL, and example in multiple myeloma or other plasma cell dyscariasis. Second type of systemic is the reactive systemic amyloidosis, or what's called secondary amyloidosis. Here I have serum amyloid associated, and fibrillar part is AA, amyloid associated, and it is associated with chronic inflammatory process. The third type of systemic amyloidosis is the hemodialysis associated amyloidosis. Here I have beta 2 microglobulin, amyloid beta 2 microglobulin, and it is seen in patients with long-standing dialysis, patients with chronic renal failure. So this is systemic amyloidosis affecting more than one organ. Second clinical type, I have hereditary or familial amyloidosis. I have number one, familial Mediterranean fever, serum amyloid associated AA. I have familial amyloidotrophic neuropathy. I have systemic senile amyloidosis. Here, the precursor protein is transthyretin, amyloid transthyretin. Third, I have a localized amyloidosis, senile cerebral. Here I have amyloid precursor, amyloid beta protein, seen in Alzheimer's disease. Second of the localized type of amyloidosis, I have amyloidosis of the thyroid in calcitonin. The precursor protein is calcitonin, and it is amyloid calcitonin. It is seen in medullary carcinoma of the thyroid. Second is in islets of Langerhans, amyloid peptide, which is seen in type 2 diabetes mellitus. So I have systemic, I have hereditary or familial amyloidosis, and I have localized amyloidosis. To speak about systemic amyloidosis. Systemic amyloidosis can be seen as primary amyloidosis, immunocyte dyscariasis with amyloidosis, or secondary amyloidosis in reactive systemic amyloidosis. Here is primary amyloidosis, plasma cell dyscariasis, and here is secondary amyloidosis or reactive systemic amyloidosis. In the primary amyloidosis, I have systemic amyloidosis. The common site of amyloid deposition is usually the muscle, including the cardiac muscle or smooth muscle of the GIT. Then it can affect solid organs, so it prefers first to occur in muscle. Here in primary amyloidosis, the common cause of death is heart failure due to deposition of amyloidosis in the cardiac muscle. Then comes other causes. In secondary amyloidosis or systemic reactive amyloidosis. Here, amyloid is deposited first in solid organs, most important kidney and liver. So, the most common cause of death is renal failure, but not liver failure. Why? Because the liver has excess reserve tissue that affection by amyloidosis does not usually affect the liver function. For organ amyloidosis, first we will speak shortly about cardiac amyloidosis. Cardiac amyloidosis may be part of systemic amyloidosis, usually of the immunocyte dyskinase, so with AL type of amyloid. It can occur as a localized form in senile cardiac amyloidosis with transthyretin type of amyloid. So the heart can be affected by either one of two types of amyloidosis. The heart is enlarged with pale gray pink subendocardial deposits, most commonly seen in the atrial chambers. By the microscope, here are the cardiac muscle, and here is the deposition of amyloid material. This will cause degeneration of the cardiac muscle that can end in cardiomyopathy and heart failure. The most important organ to be affected by amyloidosis is the kidney. Here is grossly a kidney affected by amyloid, which is slightly enlarged with pale deposition of pale brownish material. Here, under the ordinary microscope, I have homogeneous eosinophilic material. Site of amyloid deposition is in the kidney is the mesangium and wall of the capillaries of the glomeruli, then interstitial blood vessels, and in the basement membrane of the renal tubule. Here is congruent staining of the renal. So, in renal amyloidosis, it is the most common and most serious form of amyloidosis. Kidney is involved in systemic amyloidosis, reactive systemic type. So, the type of amyloid is AA. Grossly, the kidney is slightly enlarged, firm, and pale waxy in appearance. Under the microscope, amyloid is deposited in three very important sites. First is the glomerular capillary walls and mesangium, then in the interstitial blood vessels, and near the basement membrane of the tubule. These patients usually present with proteinuria, nephrotic syndrome, and the case may end with renal failure. In liver amyloidosis, in hepatic amyloidosis, it is part of systemic amyloidosis, secondary more than primary. Here, the amyloid substance is deposited in the space of this between the liver cords, and it is also deposited in the blood vessel of the portal tract. Here is bicongruent, and here is under polarized bias. So, grossly, the liver may be hugely enlarged, firm, pale, gray, and waxy. Clinically, there is hepatomegaly, but liver functions are rarely affected. They are preserved till the end. Under the microscope, amyloid is deposited in the space of this here, causing pressure atrophy of the hepatocyte in advanced stage. Also in the portal blood vessel here, portal blood vessel, and here under the polarized light. Splenic amyloidosis, the spleen shows moderate to marked splenomegaly. Amyloid material may be deposited only in the white bulb in the lymphoid follicle or in the red bulb in the wall of the blood sinusoid, and usually it is mixture of the two pathogens. When affecting only the white pulp, it is called nodular pattern or tego. For localized amyloidosis, first part in the medullary carcinoma of the thyroid, here is the tumor, and here is the amyloid material deposited in between the tumor cells. It is a localized form derived from calcitonin. Amyloid is deposited in the stroma between the tumor cells. To summarize, in systemic amyloidosis, I have plasma cell tumor, I have chronic inflammation, familial Mediterranean fever, familial neuropathy, or dialysis associated. In the localized forms, I may have senile cardiac amyloidosis, medullary carcinoma, islet cell amyloidosis, Alzheimer's disease, and cerebral angiopathy. Now, if we have a case of amyloidosis, how can we diagnose this stage? It depends on histologic demonstration of the amyloid deposition in tissue. First, by biopsy. The most favorable and easy way to get a biopsy, most common sites are kidney, rectum in the muscle cord, or the gingival tissues in systemic amyloidosis. So the simplest may be a gingival biopsy to diagnose systemic amyloidosis. Now, recently, examination of the abdominal fat aspirate stained with Congo red is quite specific, but has low sensitivity. In immunocyte-discreases with amyloidosis, serum and urine protein, electrophoresis, and immunoelectrophoresis should be done. Bone marrow aspirates may show monoclonal plasmacytosis even in absence of multiple myeloma. Thank you very much.